You are a divine healer. We invoke your sacred heart to have pity on us as we humble ourselves, turn from our wicked ways, and ask for your forgiveness. We pray for the healing of our broken heart and our broken land. Lead us to ways we can turn our nation and our world back to you for your greater honor and glory. Amen. Father, Son, Holy Spirit, amen. Good morning. Okay. Julie, can we start?
Hello. Good morning. Can everyone hear me?
Good morning. Yeah.
Good morning. Okay po. So, good morning. We are B2 groups 9 to 12 and we will be discussing the cases on bleeding. So for our table of contents, today we will be discussing approach to bleeding patients, bleeding due to anticoagulants, ITP and approach to thrombocytopenia, and lastly, disseminated intravascular coagulation. So to start with the approach to a bleeding patient, let us first review some basics on hemostasis. So the hemostatic system is how our body regulates the balance between your procoagulant and anticoagulant forces. So your procoagulant forces are composed of your platelet aggregation and the fibrin clot formation, and your anticoagulant forces are composed of your natural inhibitors of coagulation and fibrinolysis. So the major components of your hemostatic system are your platelets and other formed elements of the blood, your plasma proteins, as well as the vessel wall. So here's a diagram of your primary and secondary hemostasis. So your primary hemostasis is mainly composed of your response.
Hi, good morning.
Morning po. Yes.
Started already, Julia.
Let's go.
Go ahead.
Okay po. So your primary hemostasis is composed of the response of your platelets and your blood vessel response. So here we can see in the green box, the exposed collagen binds to and activates your platelets, and there's vasoconstriction. Secondly, your platelets release clotting factors which initiate your platelet aggregation. And in the blue box, we can see the secondary hemostasis. Now, your secondary hemostasis is the reaction of your coagulation cascade. So their clotting factors activate your thrombin, and the coagulation cascade begins. And thrombin activates fibrin strands, which adhere to form a platelet plug. Now, just to further elaborate some concepts, so your platelet plug formation is first started by your platelet adhesion. So when there is vascular injury, your platelets adhere to your denuded vascular intimal surface, and there's direct binding of your platelets to your subendothelial collagen. And this is mediated by your von Willebrand factor, which is present in both plasma and extracellular matrix of the subendothelial wall. Next, you have your platelet activation and aggregation, and this is enhanced and amplified by the humoral mediators in your plasma, and these mediators are released from your activated platelets and vessel wall extracellular matrix constituents. Your activated platelets, they promote aggregation and inhibit the naturally anticoagulant endothelial cell factors. And additional platelets are recruited, which leads to the formation of an occlusive platelet thrombus. And this platelet plug is anchored and stabilized by a fibrin mesh. Now, just to emphasize, your glycoprotein or your GP2B3A complex is the key mediator of platelet aggregation. And this is the most abundant receptor on the platelet surface. So when platelets activated, it's converted to its active form, which enables binding to fibrinogen and Willebrand factor. Next, we will be discussing your fibrin clot formation. So this takes place on your phospholipid surfaces, which is usually the activated platelet surface. Now, the immediate trigger for coagulation is vascular damage, which leads to the exposure of tissue factor in your blood. So just a quick review, there are pathways for your coagulation cascade. Your extrinsic or your tissue factor pathway, which initiates coagulation, and your intrinsic contact activation pathway, which is the amplification of coagulation. While we like to think of coagulation as a linear process, coagulation or hemostasis in general is not a sequential or a linear process. They can happen simultaneously, both your primary, your secondary, and even your fibrinolysis system. So to proceed with the discussion,
Good morning po. Can you hear me po?
I didn't get, so Dominic, Gloria finished already?
good morning po, Doc. Yes po.
Good morning po, doctors and classmates. Dominic, finish na po ata, Doc.
Go ahead. Napuputol ako. Sige.
Okay, so let's move on to the approach of a patient with bleeding, specifically in the history and the clinical manifestations. The first question we should ask in a patient with a history of bleeding would be just that. Does the patient have a history of bleeding? And this is important because prior bleeding is the most important predictor of bleeding risk. That is, if the patient has bled before, then the patient is likely to bleed again. So the questions we can ask would be, has the patient had past surgeries, and what was the response of the patient to these past surgeries? Were there any complications significant because of bleeding? So a very common surgery that patients would have would be elective tonsillectomy, and we can ask for the presence of any complications with tonsillectomy or any other surgery. The same question can be applied to whether the patient has had a past dental procedure or extraction, and if there's any complications associated with these procedures. We can also ask for a history of spontaneous or induced bleeding, and when it's induced, it could either be surgery induced or trauma induced. And this is also important because whether bleeding is spontaneous or induced will greatly give a different list of differential diagnoses based on spontaneity or inducibility. Specifically, the history and the clinical manifestations we can elicit in patients would be whether the patient has had hemarthrosis or spontaneous muscle hematomas before. So hemarthrosis would be bleeding into the joints, and this would point to patients with possible coagulation factor deficiencies, specifically in severe factor 8 and factor 9 deficiencies, so in hemophilia. These patients could have bleeding into muscle or into joints with very minor trauma or even spontaneously. We also asked for a history of mucosal bleeding. So this could point to possible platelet disorders such as von Willebrand disease. So we could ask for example, is the patient bleeding via the gums, or also if the patient has prior history of frequent or severe epistaxis or nosebleeds. Epistaxis is the most common symptom in hereditary hemorrhagic telangiectasia or HHT. So as the name implies, there's telangiectatic blood vessels, so very thin blood vessels and very thin capillaries in the nasal mucosa, and this would be very prone to bleeding. This is also the most common symptom in males with von Willebrand disease, and I will have to emphasize males because the most common symptom in females with von Willebrand disease would be heavy menstrual bleeding, as we will discuss later on. We also ask for a history of post-traumatic bleeding in the context of joint hyperextensibility, and this could point to a possible connective tissue disorder, for example, in Ehlers-Danlos syndrome. We ask for if the patient has had a history of angiodysplasia and subsequent GI bleeding, which could point to von Willebrand disease 2 or 3. And we also ask for if the patient is female for a history of heavy menstrual bleeding, which is defined as blood of greater than 80 ml or a clot which is greater than 1 inch in diameter. And as I've said previously, this is the most common symptom in females with von Willebrand disease. This could also point to a factor 11 deficiency, or the patient could actually be a symptomatic carrier for hemophilia. If the patient had a previous delivery, we asked for a history of postpartum hemorrhage. This would point to possible von Willebrand disease or a factor 8 deficiency. And a clinical pearl for factor 8 deficiency is this actually normalizes during pregnancy, but after pregnancy and upon delivery, the levels will decrease again and put the patient at increased risk of postpartum hemorrhage. Another question we need to ask in the context of bleeding history would be the presence of underlying systemic disease. So for example, if the patient has a history of prolonged steroid intake, we look for possible stigmata of Cushing syndrome, so things like abdominal striae or a dorsal fat pad. And in this context, we can also ask the patient for a history of subcutaneous bleeding with minor trauma, because we know that underlying systemic diseases may either cause or exacerbate a pre-existing bleeding tendency. We also know that all coagulation factors are synthesized in the liver. So any disease that could decrease the synthetic ability of the liver, for example, cirrhosis or liver failure, can decrease the amounts of coagulation factors and therefore put the patient at increased risk of bleeding. We also know that vitamin K is important for certain factors, specifically factors 2, 7, 9, and 10, and also the proteins C, S, and Z. So anything that could interfere with this post-translational modification of vitamin K would put the patient at increased risk for bleeding. We also know that vitamin K is a fat-soluble vitamin, and it's dependent on bile salts for its absorption. So a liver disease, for example, in cirrhosis or in liver failure, wherein there's decreased capability of the liver to synthesize bile salts, would lead to decreased vitamin K absorption. Also, diseases such as biliary obstruction that would lead to an obstruction of bile flow from the liver and the gallbladder to the intestines, where the bile salts would have its effect, would also lead to a decreased absorption of vitamin K. And also, vitamin K is absorbed in the small intestine, in the jejunum, and in the ileum. So ileal disease or jejunal disease and resection of that would lead to a decreased absorption of vitamin K. We also know that the spleen is the major blood filter of the body. So any disease that would cause splenomegaly, such as, for example, portal hypertension, would lead to thrombocytopenia and as a result, an increase in bleeding tendencies. Just a brief mention on platelet counts. The normal value is from 150 to 450, and bleeding occurs at less than 10 to less than 20. Now, the thing to note is that most procedures can be performed in patients with a platelet count of 50,000 microliters or 50. So the lower limit of normal of platelet count would be 150, but even a platelet count of as low as 50 is okay for patients to have procedures such as minor surgeries or surgeries performed. The second question we should ask would be whether the patient has an intake of possible pro-hemorrhagic medications or dietary supplements. These include aspirin and NSAIDs, clopid and prasugrel, fish oil or omega-3 fatty acids inside the fish oil, and also vitamin E. Just a brief overview of these pro-hemorrhagic medications. Aspirin and NSAIDs, as we know, they inhibit COX-1 or cyclooxygenase 1 enzyme. And by inhibiting COX-1, they decrease the production of prostaglandins from arachidonic acid, which is good when we're talking about pain. But the side effect of that is that there's going to be a decrease in prostaglandin G2 and prostaglandin H2 synthesis. And as a result of that, there's going to be a decrease in primary hemostasis and therefore an increase in bleeding risk. Now, another pro-hemorrhagic medication would be these anti-aggregant agents, so things like clopidogrel and prasugrel. What happens here is that usually ADP binds to the P2Y12 receptor on platelets, and in doing so, it activates a series of downstream cascades that lead to platelet activation. Now, these antiplatelets, for example, clopid, these antagonize the P2Y12 receptor, therefore it would decrease the downstream platelet activation and put the patient at increased risk of bleeding. We also look for the presence of a history of pro-hemorrhagic dietary supplements. So if the patient is taking large amounts of fish oil, or not even fish oil, if the patient is just taking the active ingredient inside this fish oil, which is concentrated omega-3 fatty acid, this could also put the patient at increased risk of bleeding because omega-3, or in general, polyunsaturated fatty acids, what they do is they alter platelet biochemistry and they increase the production and the levels of prostaglandin I3. And prostaglandin I3 has important aspects in inhibition and antagonism of thromboxane A2, which is important in primary hemostasis. It antagonizes the pre-existing thromboxane A2, and not only that, it also reduces the synthesis of new thromboxane A2, leading to a decrease in primary hemostasis and therefore an increase in bleeding tendencies. We also ask for the presence of large amounts of vitamin E intake. Vitamin E is a good antioxidant in that it is able to inhibit the synthesis of reactive oxygen species. But a downside to vitamin E, especially when it's taken in large amounts, is that it also inhibits the protein kinase C pathway, and in doing so, increases the bleeding tendency of the patient. And the last question we can ask would be whether the patient has a history of thrombosis. Thrombosis is divided into arterial and venous. Risk factor, and the most significant risk factor for arterial thrombosis would be the presence of atherosclerosis. So we have to ask that and elicit that on history. We also ask for possible risk factors related to venous thrombosis, and the most common of this would be deep vein thrombosis or DVT. Increasing age is a major risk factor. Other risk factors include immobility, so if the patient is bedridden, or if the patient has a fracture that renders the patient immobile, or maybe because of surgery, either surgery per se, which also increases the hypercoagulable state, or immobility brought about by surgery can lead to an increased risk for DVT. Malignancy is a hypercoagulable state, as is hormonal therapy with, for example, OCPs, obesity as well, and family history, which speaks to genetic predisposition. All of these are risk factors for venous thrombosis. And another important question to elicit would be whether the history of thrombosis is idiopathic or precipitated by any of these events. And so that's it for history and clinical manifestations. And we move on to lab exam.
Hello, can you hear me?
Very good.
Hello. Okay, so we move on to the laboratory examination for cases of bleeding. For a while. Hello?
Go ahead.
Look, sorry. Technical difficulties.
Sige lang.
Can wait.
Ay, record nga pala ako. Shit. Nagawa mo. Tataka akong bagdang sa wala. Ang bad ko. Kita bad ka.
Ayun. So primarily, we have 5 considerations for the laboratory examination. Specifically, we have the screening assays, the mixing studies, specific factor assays, tests for antiphospholipid antibodies, and other coagulation tests that are available. So first, we start off with the screening assays, which is primarily the prothrombin time and the activated partial thromboplastin time. So as we know, the prothrombin time The prothrombin time assesses for both the extrinsic and common pathways. So it is based on the principle that when there is citrated plasma and calcium and thromboplastin is added, there will be a clot formation. So the normal value for this would be 12 to 14 seconds, and it is worth mentioning that the prothrombin time is sensitive for factor 7 deficiency. However, prothrombin time varies among different laboratories. So to normalize this, especially for those undergoing warfarin therapy, it utilizes the International Normalized Ratio, which standardizes prothrombin time results across different laboratories. So for example, if you have a prothrombin time done at one laboratory with INR, it would be interpreted as the same in another institution. So the INR is based on the patient's prothrombin time divided by the normal mean of PT raised to the International Sensitivity Index. So the ISI is a value produced by manufacturers based on the International Reference Thromboplastin Preparation, which is done by the WHO. Next, we have the APTT, or the Activated Partial Thromboplastin time, which assesses for both the intrinsic and common pathways. The
Di ba pabot na ng tablet? Miguel, pabot ng tablet. Uy, Miguel, pabot ng tablet po. Ang point ka ng ang point ka ng magulang. Nice na.
hello.
Yes, we can hear you, Stephen.
Hello. Can you hear me? Sorry.
Yes, Stephen, go ahead.
Okay, so for the activated partial thromboplastin time, again, it assesses for both the intrinsic and common pathways, and it is based somewhat on a similar principle as the prothrombin time, which is the addition of a phospholipid and the negatively charged activators to recalcified plasma. This has a longer normal value of 26 to 38 seconds, and it is most sensitive for factor 8, 9, 11 deficiencies. It's worth mentioning as well that activated partial thromboplastin time is useful for those undergoing heparin therapy. So we have here a diagram from Parsons which explains the usage of PT and APTT. As you can see in the green, the PT assesses for the extrinsic pathway. Moving on. We have the uh, abnormalities seen when there is prolonged APTT and PT. So, as mentioned earlier, so for APTT, no, as mentioned earlier, those indicated for APTT would be those who have factor 8, 9, 11 deficiencies and those undergoing heparin therapy. For PT, what's happening? So for prolonged PT, we have the factor 7 deficiency and early vitamin K deficiency. So for vitamin K deficiency, we see that prolonged PT first because as we know, factor 7 is a vitamin K dependent factor along with factors 2, 9 and 10. In prolonged APTT and PT, we can deduce that it's a C in the common pathway since it prolongs both PT and APTT. As seen here in the table, it's factor 2, 7, and 10 or fibrinogen deficiency. And for those taking direct thrombin inhibitors. So mixing studies is used to evaluate a prolonged APTT to distinguish between factor deficiency or the presence of inhibitor. So I move your attention here to the diagram. So if we have an abnormal plasma or prolonged APTT, we mix it with normal plasma which contains all the factors. If the APTT normalizes, we can deduce that there is factor deficiency. However, if it remains prolonged after the addition of normal plasma, we can see that there is inhibitors such as lupus anticoagulants, neutralizing antibodies, and other inhibitors. We also have specific factor assays, which is used to guide appropriate therapy for hereditary single factor deficiencies, such as your hemophilia A, which is a deficiency of factor 8. So it is a modified mixing study. So we have here, for example, we know that a patient with hemophilia A would have a prolonged APTT due to the deficiency of factor 8. If we add normal plasma, we would expect that APTT would normalize. However, if we add a plasma which we know as factor 8 deficient and it is prolonged, we could deduce that that patient has factor 8 deficiency and is a hemophilia A patient. Next, we have testing for antiphospholipid antibodies. So antiphospholipid antibodies are those antibodies which are directed against phospholipids or your phospholipid binding proteins such as your beta-2 microglobulin. In vitro, they are known as lupus anticoagulants and they interfere with phospholipid-based assays such as your PT and APTT. To correct this, we laboratory scientists have devised assays such as your dilute Russell Viper venom test and your tissue thromboplastin inhibition test, which improves sensitivity to lupus anticoagulants. Lastly, we have other coagulation tests such as your thrombin time and reptilase time, which tests for fibrinogen deficiency. They are both prolonged when you have deficient fibrinogen. However, it is worth mentioning that for reptilase time, it is unaffected by heparin and your direct thrombin inhibitors such as your dabigatran. Quantitative fibrinogen assay is also available, and D-dimer assay is used to detect D-dimer, which is a fibrin degradation product, and is elevated in patients with DIC. That's all. Thank you.
So we will be discussing the first case study for today, anticoagulant-induced bleeding. Can you hear me po? Hello? Okay po.
Yes, it's clear.
So we have a 50-year-old female that was brought to the emergency department for decreased sensorium. For the subjective data, she has a history of severe mitral valve prolapse for which she had mitral valve replacement at age 30. She is maintained on warfarin 5 milligrams once daily. And moreover, on physical exam, she is drowsy with unintelligible speech, and motor examination reveals right-sided weakness. So, these are some of the additional information that should be asked. History of head injury. Trauma must be considered in any patient with an unexplained acute neurologic deficit. History of liver disease should also be asked because this results in decreased bile salt synthesis, leading to impaired vitamin K absorption and deficiency, which can induce intracranial hemorrhage. History of malabsorption syndromes or diseases like cystic fibrosis, celiac disease, chronic pancreatitis, or Crohn's disease, which can alter absorption of fat-soluble vitamins, including vitamin K. History of chronic hypertension, which is the most common cause of hemorrhagic stroke. The reason for this is that high blood pressure can cause thin-walled arteries to rupture, releasing blood into the brain parenchyma. History of hematologic disorder should also be asked. Examples would be leukemia, aplastic anemia, or thrombocytopenic purpura, which can present as multiple intracerebral hemorrhages. So the PE is geared towards prompt examination of the etiology of the brain involvement. We can ask the relatives regarding the onset of the patient's signs and symptoms. Ischemic stroke often present with progressive and sudden presentation of focal neurological deficits or FND, while hemorrhagic stroke often present with maximal FND from time of onset. It is also important to take note of signs of increased intracranial pressure, including papilledema, headache, nausea, and vomiting, for these point to a more ischemic type of stroke. We should also assess the skin and mucous membranes because this offers diagnostic clues in some of the hematologic disorders. Stigmata of chronic liver disease should also be assessed. This includes jaundice, spider angioma, palmar erythema, and abdominal distension. So the CBC results are as follows. Hemoglobin and hematocrit are low, which can indicate blood loss due to blood thinner or anticoagulants such as warfarin. WBC is also increased. The relationship between increased WBC count and intracerebral hemorrhage is complex. According to a study of Andrea Morotti in 2016, leukocytes interact with platelets, endothelium, and coagulation factors and have been widely recognized as important contributors to facilitating hemostasis. So in the same study, they have concluded that the WBC differential count can be used as prognostic factors in patients with hemorrhagic stroke. The predicted probability of hematoma expansion was inversely correlated with neutrophil count and directly correlated with monocyte count in a linear and dose-dependent relationship. So as for our patient, she has a slight elevation in the neutrophil count, which indicates decreased risk in developing expansion of the hemorrhage or hematoma. So warfarin therapy intake, as I said a while ago, yung history ng patient is most often monitored using prothrombin time and INR. So prothrombin time is a test, as mentioned again by Stephen, a test which is sensitive to reductions in levels of prothrombin factor 7 and 10. So this test is performed by adding thromboplastin. So thromboplastin vary in their sensitivity to reductions in the level of vitamin K-dependent clotting factors. So the INR was developed to circumvent many of the problems associated with prothrombin time. Warfarin is administered in doses that produce a target INR of 2 to 3. An exception of this is patients with mechanical heart valves, particularly those in the mitral position, like in the case of our patient, where the INR of 2.5 to 3.5 is recommended. Studies stated that heart pathologies, including atrial fibrillation and mechanical heart valves, increase risk of cardioembolic stroke when INR fall less than 1.7, but increase in intracranial bleeding with INR values of more than 4.5, which is apparent in our patient with an INR value of 7. And lastly, results of cranial CT scan showed left cerebral hemorrhage. So common causes of bleeding are factor and vitamin deficiencies and also coagulopathies. So for our differential diagnosis, we have warfarin-induced cerebral hemorrhage, vitamin K deficiency related to chronic liver disease or malabsorption syndrome, and hypertensive intracranial hemorrhage. So these three may all present with decreased sensorium, drowsiness, and focal neurological deficits such as contralateral hemiparesis and slurred speech. Warfarin-induced hemorrhage and vitamin K deficiency related to GI pathologies both present with prolonged prothrombin time, decreased hemoglobin, and hematocrit. This is in contrast with hypertensive intracerebral hemorrhage, which can present with normal prothrombin time. We can now rule out hypertensive ICH because aside from prothrombin time, the patient does not have any history of chronic hypertension, which is the primary risk factor for developing hypertensive ICH. We could also rule out vitamin K deficiency secondary to liver and intestinal pathologies because the patient does not have a history of liver disease nor surgeries or diseases involving the proximal bowel that can induce malabsorption syndromes. Examples of these are celiac disease, pancreatitis, and Crohn's disease. So for our primary diagnosis for this case, spontaneous left intracerebral hemorrhage secondary to warfarin therapy. Thank you.
Hello. So our patient was given warfarin as maintenance due to a mitral valve prolapse and subsequent valve replacement 20 years ago. She was likely given this drug to avoid the formation of a thromboembolic state. To understand how our patient developed intracerebral hemorrhage due to warfarin therapy, let us first have a brief review of how warfarin acts as an anticoagulant drug. So warfarin is a water-soluble vitamin K antagonist, therefore it interferes with the synthesis of vitamin K-dependent clotting factors, namely factors 2, 7, 9, and 10, as well as vitamin K-dependent anticoagulant proteins, protein C and protein S. In a normal individual, the conversion of your non-functional clotting factors or your prozymogens to functional zymogens requires carboxylation. But where do they get the extra carboxyl group from? This is where your vitamin K comes in. Vitamin K from the diet is reduced by your vitamin K reductase, and the reduced vitamin K acts as a cofactor for your carboxylase enzyme to activate your prozymogens into your functional zymogens. A person given warfarin will essentially break this cycle because warfarin inhibits vitamin K reductase. Thus, the vitamin K from the diet will not be reduced and no cofactor for carboxylase will be produced. Therefore, this impaired cycle produces only partially activated clotting factors with reduced or absent activity. The end result is a system with reduced coagulating factors present, thereby reducing the risk of producing thromboembolic states, which is the main goal of warfarin therapy. The clinical manifestations of warfarin use are very straightforward. Warfarin is an anticoagulant drug, therefore most of its side effects as well as complications would involve bleeding. Bleeding may be mild in the form of epistaxis or hematuria, but may also be severe in cases of intracerebral hemorrhages or GI bleeds. Some studies have shown that bleeding due to warfarin over anticoagulation most predominantly manifested as GI bleeding, followed by mucocutaneous bleeding, and then urinary bleeding, with intracerebral hemorrhage being rare. However, it was the presence of intracerebral hemorrhages that was most predictive of mortality within 30 days. Typically, bleeding with the use of warfarin is avoided by maintaining a stable therapeutic range INR. Acute presentations of intracerebral hemorrhages include abrupt onset of focal neurologic deficits, as well as decreased levels of consciousness. There may be nausea, vomiting, or headaches, as well as dysarthria. A study by Yungol et al. Analyzed possible risk factors for bleeding with warfarin use. They found that younger patients taking warfarin had less risk of bleeding as compared to those in the older age group. Moreover, achieving a stable therapeutic range INR was also found to be less of a risk for developing spontaneous bleeding. Renal function is also important because warfarin is mainly eliminated through the kidneys, and poor renal function was found to be predictive of bleeding episodes in patients. The use of acetylsalicylic acid was also mentioned because of its wide usage, as well as that concomitant use of acid agents with warfarin enhances bleeding due to its antiplatelet properties. And lastly, it was found that patients who have a low level of education tended to present in the emergency room more frequently due to bleeding. Therefore, it is imperative for doctors to strongly consider giving these patients more education on their condition, as well as the drugs that they are taking in terms of its side effects and complications. There are other multiple risk factors that influence the formation of intracerebral hemorrhages, with hypertension being the most important modifiable risk factor. Studies have shown that poor blood pressure control strongly correlates with the formation of persistent ICH. People in the older population, as well as those who have excessive alcohol use, so those who smoke, and those who have diabetes also have increased risk. And as mentioned earlier, the manifestations of warfarin therapy or over anticoagulation is bleeding, worst of which is your ICH. But there are also other complications with warfarin use, such as skin necrosis. Although rare, it is usually seen 2 to 5 days after the initiation of warfarin therapy. It presents as well-demarcated erythematous lesions on the thighs, buttocks, and toes, and this is most predominant in those with congenital or acquired deficiencies in protein C or protein S. Another important complication with warfarin use is that it is teratogenic. Warfarin crosses the placenta and can cause broad fetal abnormalities such as nasal hypoplasia, stifled epiphysis, as well as fetal bleeding. The diagnostic workup of a patient presenting with bleeding with a history of warfarin therapy is composed mainly of the following. First is the CBC with platelet count and subsequent blood typing and cross-matching. The patient is presenting with bleeding, so it is important to assess the blood count so as to guide whether or not transfusion is necessary at this point or at any point during the management of our patient. Moreover, the CBC will show us if there are any other deficiencies in our patient which may lead to bleeding, such as low platelet count. Elevated WBC, as stated earlier, was also suggested to have or go with the development of intracerebral hemorrhages. The use of blood typing and cross-matching is also very important because if at any point during the management of our patient there is a need for blood transfusion, we want as much as possible to avoid any blood incompatibilities. For neuroimaging, it is an important tool to diagnose intracerebral hemorrhages. We should request for a non-contrast CT scan because in the CT scan, we can observe the hematoma as to its location, the extension to the ventricular system, degree of edema, mass effect, or structural shifts. We can also likewise request for a CT angiography to determine whether there is a high likelihood that the hematoma will continue to expand. Lastly, but most importantly, we should request for your APTT and PT with INR. Your APTT, as discussed earlier, evaluates the intrinsic and common pathways while your PT evaluates the extrinsic and common pathways. These are necessary to determine whether there are other deficiencies in these pathways. The INR is typically computed using the PT result for people who are on warfarin therapy. Since PT results are relative, INR is used to standardize the results. It is used mainly to assess the risk of bleeding as well as the coagulation status of the patient. So a patient on a vitamin K antagonist such as warfarin should have an INR in the therapeutic range between 2 to 3 or 2.5 to 3.5. Studies have shown that an INR of about 4.5 above is already in the critical state and have a high risk of bleeding. It is recommended that a patient with a mitral prosthetic valve have a target INR of 3 to 3.5. INR levels below the target range is associated with increased thrombosis up to 3 times that of normal, while those below the therapeutic range have increased risk of bleeding. And normally, in a patient taking warfarin, PT with INR is measured at least once a month or every 3 to 4 weeks. Thank you.
Hello po, good morning po. Clear po ba ako? Hello?
Yes, go ahead.
Thank you po. Okay, so for the reversal of anticoagulation in patients with anticoagulant-associated ICH, this is a medical emergency, and we know that anticoagulation when it comes to ICH is associated with greater hematoma growth, neurologic deterioration, and increased risk of death and major disabilities compared to that of with no anticoagulation. Therefore, to manage the case of our patient, we must remove or discontinue the anticoagulant therapy after sufficient evaluation. So next, acute management for intracerebral hemorrhage also calls for the immediate attention to blood pressure and airway protection. Thereafter, upon evaluating these two factors, we can switch our focus to medical and surgical management. For patients, number 3, for patients taking vitamin K antagonists or your VKAs such as warfarin, in our patient, we also have dicumarol and other drugs. Rapid correction of coagulopathy can be achieved by infusing your PCC or prothrombin complex concentrates, which is concurrently administered with your vitamin K in IV slow infusion. We have an alternative for PCC, which is your fresh frozen plasma. However, this is not recommended if PCC is available. So we also have INR monitoring and reinitiation of anticoagulants. So now, why do we need to manage the blood pressure? So the importance of blood pressure management lies on the evidences linking acute hypertensive response after ICH to poor outcomes, such as increased mortality, disability, and possible risk of hematoma expansion. So take note that after development of ICH, there is this so-called acute hypertensive response that a patient undergoes. So blood pressure management is really a necessity in these cases. So next, so we've mentioned that among the managements given, we have your PCC as well. So this was extensively discussed a while ago already. So it contains your factors 2, 7, 9, 10, proteins C, S, and Z. So these are vitamin K dependent factors. And the importance of giving your PCC is that we must also monitor for increased risk of thromboembolic events, because PCC may not be suitable for patients with thromboembolic diseases within the previous 3 months. So what do I mean by thromboembolic diseases or related events? We have your myocardial infarction, DIC, stroke, transient ischemic attack, angina pectoris, or severe peripheral vascular diseases. So again, if these occurred within the previous 3 months, we must exclude the patient for the use of PCC. Again, upon giving PCC, we must monitor thromboembolism during and after administration. So next, in combination with your PCC, we also give vitamin K given via slow IV infusion. So monotherapy is usually insufficient for reversal in the first hours, but again, this should be part of all acute VKA reversal strategies. Next, we have your INR monitoring, which is also part of the management. So what's important about INR monitoring is that whenever there is prolongation or higher values, as what was mentioned by Kyle and Dan a while ago, this also predicts bleeding risk and poorer prognosis. So this is also a factor we look at when prognosticating about hematoma expansion. Okay. Then lastly, for anticoagulant reinitiation, we need to ask kung kailan ba dapat mag-reinitiate or kailangan bang mag-reinitiate ng anticoagulant therapy. Because again, take note, it is the anticoagulant which caused the ICH of the patient in this case. So, we have several associations or groups here which gave guidelines on reinitiation. So for the European Stroke Initiative, they recommend that patients reinitiate with anticoagulant therapy after 10 to 14 days, also depending on the risk of thromboembolism and ICH occurrence. For the American Heart Association, we can reinitiate 7 to 10 days after developing ICH. Then for the American College of Chest Physicians, they don't have clear guidelines on restarting warfarin. However, they noted that we must start prophylactic dose of heparin the day after ICH onset. Okay, so we have here another specifications for those with mechanical heart valves, just like in our patient who has a left ventricular valve. So it is prudent to restart anticoagulation safety after 7 to 14 days. Okay, so for the prognosis of patients with cases of ICH, so ICH expansion can be seen in 45% of patients despite correction of coagulopathy. 1 month mortality remains approximately 40%. And lastly, after the first year, there is still a great percentage, which is 75%, who become severely disabled or deceased. So that's it for the case on.
Yeah, so the ICH, this is may not is guarded. But with regards to the coagulopathy which caused the ICH, what is the prognosis, or what do you tell the relatives or the patient, not the patient in this case, but the relatives as to the cause? I mean, what is the prognosis of the warfarin toxicity?
Doc, if there is rapid reversal of anticoagulation, there would be good prognosis naman po.
Okay, so what is important is really identifying what actually caused it. Kasi if you identify that it was due to the anticoagulant right immediately, and you reverse the toxicity, that of course depend the other bleeding issues are unlikely to happen. Of course, when you relate it to the ICH, it would depend also on the extent of the ICH. Okay, so
Yes po,
thank you.
I agree po. Thank you po.
Thank you.
Hello, good morning.
Morning.
Naririnig po ba? Okay. So we now discuss immune thrombocytopenic purpura and the approach to thrombocytopenia. So we have a case of a 25-year-old female whose chief complaint is weakness. Upon history, it was noted that she's had month-long menses wherein she self-medicated with unspecified herbs. However, bleeding persisted. She also noticed peripheral weakness, which prompted her to seek consult. So for the salient features, the age of the patient, female, menorrhagia, weakness, bruises, gum and pharyngeal bleeding, and the preferential use of non-dominant hand. On CT, left cerebral hemorrhage was noted. So for the laboratory results, hemoglobin, hematocrit, and lymphocytes and platelets are low, whereas white blood cells and neutrophils are increased. Possible,
May ginamit siya.
yes,
Hello. Yeah, sorry. Question before we go ahead with the labs, no? Although they're still part of the patient's history because this patient comes to you with the labs. Is there any, what else would you like to know? I cannot tell you the answer now, no? Because I don't know this patient but
Ano ko niya.
apart from,
Pero alam ko
oh, there, sige, sorry.
yes,
I preempted your report. Okay, sige.
it's okay.
Go ahead. Sorry.
So, additional info that should be asked. The menorrhagia and weakness, we should have a detailed history of it. As for the menorrhagia, we have to know the usual volume of her menses by asking numbers of pads used, the regularity of period, and for how long does she normally have her menses. And for the weakness, we should ask for the onset of it and what are the occurrences prior to the weakness. It is also necessary for us to ask any traumatic events, which could also be the cause of the cerebral hemorrhage. Next, fever. We should also ask for occurrences of fever and infection, as thrombocytopenia can occur with variety of infections. The mechanisms may include immune-mediated platelet destruction, bone marrow suppression, or platelet consumption. Next, we also have to ask for any underlying liver disease and hypersplenism, as the liver is the site of thrombopoietin production. Therefore, if there's any liver pathology, TPO decreases, which could lead the patient to thrombocytopenia. If available, prior platelet count should be asked, as stable platelet count is less concerning than a new or decreasing count. Next would be medications, as discussed earlier, and then family history of any bleeding disorder or thrombocytopenia. Lastly, for the questions that had to be asked for history, the dietary practices, whether the patient is vegan or there's an excessive zinc ingestion or any bariatric surgery, which could also cause thrombocytopenia. For the physical exam, we have to palpate for the liver for any signs of liver pathology and check for any hypersplenism or check for any splenomegaly, which could be a sign for hypersplenism. And we also have to palpate for lymph nodes, as this could be a sign for any infection. And then neuro exam, as the patient had weakness and there's a CT finding for cerebral hemorrhage. Thank you.
So for our differential diagnosis, we are considering immune thrombocytopenic purpura or ITP, drug-induced thrombocytopenia, and infection-induced thrombocytopenia. So the ones in red font are the characteristics which are present in our patient. Our first differential for this case is ITP, since the important characteristics evident in our patient that may differentiate ITP from the other differentials is first, the presence of mucocutaneous bleeding, either in the oral mucosa, GI bleeding, or heavy menstrual bleeding. Second, the presence of CNS bleeding, and third, the presence of ecchymosis. Our patient presented with active bleeding of the gums and posterior pharynx and menorrhagia, which lasted for a month. She also had CNS bleeding due to the left cerebral hemorrhage, which happens rarely in ITP, but was present in our patient. She also presented with ecchymosis, as proven by the multiple bruises on her arms and legs. These are classic characteristics of ITP that are not commonly seen in both drug-induced and infection-induced thrombocytopenia. For the next differential, we are considering drug-induced thrombocytopenia due to the patient's history of self-medication with herbs. According to Williams, taking herbal remedies should be considered as a potentially causative agent in any thrombocytopenic patient. Drug-induced thrombocytopenia is usually not severe, but our patient had a severe manifestation as she presented with a CNS bleeding. In relation to this, according to Harrison's, drugs that commonly produce thrombocytopenia are chemotherapeutic drugs and other drugs such as acetaminophen, amlodipine, furosemide, ibuprofen, and more, and yet there was no mention in the history of the patient of such drug intakes. For the last differential, we are considering infection-induced thrombocytopenia since it is the most common non-iatrogenic cause of thrombocytopenia according to Harrison's. Also, since the patient presented with bleeding and leukocytosis. Although this would be the less likely diagnosis since the patient did not present with clinical symptoms of a viral or bacterial infection. Our patient presented with acute leukocytosis since it is a well-established response to the CNS bleeding. Leukocytosis played a role in hemostasis to reduce the bleeding. In contrast to this, according to Williams, the leukocytosis seen in patients with infection-induced thrombocytopenia should be further screened for HIV, HCV, and HBV. Therefore, our primary diagnosis for this case is immune thrombocytopenic purpura. So, ITP is the most common cause of isolated thrombocytopenia according to Williams. It can affect males and females of any age. Although childhood ITP is typically acute in onset, often developing after a viral infection or vaccination that resolves spontaneously within a few weeks up to 6 months. In contrast to this, adult ITP generally is a chronic disease of insidious onset and rarely resolves spontaneously. Primary ITP denotes the absence of any other identified pathology, while secondary ITP may be due to HIV, SLE, and hepatitis C.
Hello. Magandang umaga po. So we're talking about immune with thrombocytopenic purpura. Again, it has two types, the primary and the secondary. The only difference between these two are their etiology. So primary ITP again is mentioned to be due to isolated thrombocytopenia, and secondary ITP is thrombocytopenia associated with the presence of other conditions. So looking at this figure, it is most commonly associated with systemic lupus erythematosus. Based on onset, we have childhood and adulthood. Goes just reiterating to you, looking at this table, that childhood ITP is usually acute in onset with symptoms last 1 week, and they usually resolve spontaneously in 83% of the cases. And adulthood ITP is usually used in process with symptoms lasting more than 2 months, and they rarely resolve. So symptoms and signs of ITP depends not only on the platelet count, but also on the nature of coexisting condition that can increase the tendency to bleed. So looking at this table, all of these conditions have common denominator, and that is they affect the platelet function of the individual. So classic manifestations of ITP would present with mucocutaneous bleeding, specifically at the oral mucosa, presenting with ecchymosis, PTK, purpura, epistaxis, menorrhagia, GI, and gingival bleeding. Classically, they present with non-palpable and non-blanching purpura. In severe cases, they could present with hemorrhagic bullae, and commonly, they would present with bleeding after surgery, trauma, or tooth extraction. So this slide would present to you illustrations of the classic finding. You can see here the mucosa, the ecchymosis, the epistaxis, the menorrhagia or the heavy menstrual bleeding, the gingival bleeding, the PTK, and the purpura. So history and PE are usually unremarkable. What's important to us about the patient is their family history, because from there on, we could discriminate the familial thrombocytopenic syndromes from ITP. And another important findings that fatigue is one of the common but often neglected complaints of patients with primary ITP. So complications-wise, these are rare and usually occurs in patients with severely low platelet count. So our patient presented with left cerebral hemorrhage. It generally occurs in patients with platelet count of less than 10 raised to 10 raised to 9 per liter. Our patient in the case have platelet count of 3 times 10 raised to 9 per liter. And this is usually associated with trauma or vascular lesions. And the incidence of this complication is usually highest in older patients, specifically more than 60 years of age. Another complication would be wet purpura or the blood blisters in the mouth. Okay? They could also present with retinal hemorrhages that in worst case could lead to blindness. And lastly, they also have slightly increased risk of venous and arterial thrombosis. So what is good about patients with ITP is that majority of them have good prognosis, with mortality rate being only slightly higher than that of the general population. Okay? It is important to take note that ITP patients with severe thrombocytopenia, that is platelet count of less than 30 times 10 raised to 9 per liter, do not respond to any therapy within 2 years, have fourfold increased risk of death compared to the general population.
Initial laboratory workups include a CBC and peripheral blood smear. In a case of ITP without complications, we should see an isolated thrombocytopenia without erythrocyte or leukocyte abnormalities. However, in our patient, we did see leukocytosis, and as explained before, that may be due to the presence of the intracranial hemorrhage. According to Williams, some other common findings are platelet anisocytosis on blood film, and the size of the platelet may be abnormally large or small, but the morphology is normal. Furthermore, to diagnose this as primary ITP, we need to rule out possible secondary causes. Some recommended workups include viral etiologies such as Hep B and C and HIV, and for H. pylori. Also, depending on the clinical presentation of our patient, other causes of secondary immune thrombocytopenia should be considered and tested as listed. Bone marrow examination is not usually a part of the initial workups, as it is not recommended unless the presentation is atypical of ITP, or the patient does not respond to initial therapy. But findings for ITP are usually normal or an increased number of megakaryocytes of normal pathology, normal morphology. The treatment of ITP on these three goals: to decrease the reticuloendothelial uptake of the antibody-bound platelet, to decrease antibody production, and to increase platelet production. First of all, when managing patients with no bleeding and platelet counts that are consistently above 30 times 10 to the 9th, it is recommended to withhold treatment and just observe periodically, as they are at low risk for clinically important bleeding and do not have increased mortality related to thrombocytopenia. Next, for patients with platelet counts lower than that, but without significant bleeding symptoms, severe thrombocytopenia, or signs of impending bleeding, these may be managed as outpatients using single agents. Glucocorticoids, particularly prednisone, have been used as first-line treatment for increasing platelet count in the patient. In 2/3 of patients, platelet counts can increase to greater than 50 times 10 to the 9th within 1 week. Overall, patients usually respond within 3 weeks, and so the recommended dosage is 1 milligram per kilogram per day for 3 weeks with dose tapering. And if they do not respond after 3 weeks, other therapeutic options should be considered. Intravenous immunoglobulin, or IVIG, is also used to rapidly increase the platelet count. This can be seen in 75% of patients with chronic ITP. The effect is transient, lasting 3 to 4 weeks. And this is why it is a first-line therapy in childhood ITP, because their thrombocytopenia is usually transient as well. In adults with ITP, IVIG is usually indicated for patients with life-threatening bleeding when a prompt increase in platelet count is needed, or when glucocorticoids are contraindicated. And because its effect is not affected by splenectomy, it is more efficient in post-splenectomized patients than anti-RH. Anti-RHD must be used only in RH-positive patients. This is due to its mechanism of action of limited hemolysis. Furthermore, monitoring is required for 8 hours after the infusion because of the rare complication of severe intravascular hemolysis. For patients with severe ITP and or symptoms of significant bleeding, hospital admission is recommended with a combination of high-dose plus IVIG or anti-RH. Our patient presents with these clinical manifestations, such as severely low platelet count and also the significant bleeding from the intracranial hemorrhage. So we would highly recommend admitting her and starting the combined modality therapy. Patients with refractory ITP or experiencing relapses after first-line therapies can opt for second-line therapies. Rituximab is a B-cell antibody that has shown efficacy in the treatment of refractory ITP. Long-lasting remission occurs in about 30% of these patients. It should be noted that with the depletion of B cells, this can reactivate latent viruses, especially hepatitis B. So those starting this therapy should be screened for HPV beforehand. TPO agonists are used in order to stimulate platelet production, as they have been found to have normal levels of TPO, as these patients have been found to have normal levels of TPO, despite the presence of platelet destruction. So these are recommended for adults at risk of bleeding who relapse after splenectomy, those who have been unresponsive to at least one other therapy, and it can be used as a short-term treatment before splenectomy in the case that ITP spontaneously resolves. And splenectomy is probably the last choice, as it is invasive, and it is used for patients who relapse after glucocorticoids are tapered. It decreases antibody production and platelet destruction, and it has a high cure rate, as 85% of chronic ITP patients respond well to the procedure, and 60 to 66% remain in remission after 5 years. There is, however, an increased risk for serious bacterial infection, bleeding, and thrombosis. Finally, accessory treatments are available, and they're designed to reduce bleeding without necessarily affecting the platelet count. For those experiencing excessive mucosal bleeding, antifibrinolytics are given. For local bleeding, we can control it through compression and with the use of gelatin sponges, fibrin sealants, and antifibrinolytic emetic gels. And in the case of our patient who's experiencing menorrhagia, which is a common problem in patients with chronic ITP, we can recommend oral contraceptives or hormonal intrauterine devices with antifibrinolytic drugs. This would help reduce the excessive menstrual bleeding. However, we must also have them undergo a gynecologic evaluation of uterine problems. And education is very important for the patient in order for them to prevent and control their symptoms. They should avoid using antiplatelet drugs, doing contact sports and activities that increase bleeding risk, and maintain adequate dental hygiene. Thank you.
Hello. Yes, go ahead.
Hello, good morning.
Yes, good morning.
Doc,
Morning, Kiara. Go ahead.
yes po, sorry. So for our last case, under the case of bleeding, we have a patient with 64-year-old male with a stage 4 squamous cell carcinoma on the tongue. He was brought to the ER due to fever and difficulty of breathing. He was then admitted for pneumonia and started on antibiotics. On the second hospital day, the relatives had blood coming from the side. Thing was placed, which only became soaked with blood and needed to be replaced every few minutes. The patient then had gum bleeding, progressing to profuse bleeding from the mouth. So, for the salient features, the patient being a 65-year-old male, this increases the risk of the patient for thrombosis. He also presented with fever and difficulty of breathing. Another salient feature would be the stage 4 squamous cell carcinoma. As for malignancy and solid tumors are associated with the release of procoagulants, and this is also seen as one of the causes of GIC. And then the presentation of bleeding coming from the IV site, gums, and progressive the mouth is a glaring or a clue that we can see primary and secondary hemostasis. So before we proceed with the results, these are the other additional assessment that we can um, gather from the clinical history and from physical exam in order to rule out other differential diagnosis and to arrive with our clinical impression for our patient. So the first one would be the smoking history. Since the patient has stage 4 was one of the causes of headache malignancy, we should ask the patient how long has he been smoking, and if the patient has discontinued because smoking can increase the risk for bleeding as it causes widespread clot formation which further depletes your platelets and thus further leading to bleeding. Also, we should ask regarding the patient's medications such as heparin, anticoagulants, and chemotherapeutic drugs. Another information we can gather from the patient would be his state of immunodeficiency and other previous viral infection, such as HIV, and herpes virus, as this could also be one of the causes of GIC or could further complicate and increase the risk of bleeding for our patient. Since the patient diagnosed as well with stage 4, most likely this cancer has metastasized to other organs. So it is important to also ask for other organs. It has already metastasized to the liver, lungs, kidney, and to the brain. So aside from that, we could also ask regarding the patient's previous bleeding episode. Has this been or is it recurrent, as this increases the risk of bleeding. And then for other comorbidities such as myocardial infarction, pulmonary embolism, liver diseases, liver disorders, and deep vein thrombosis episodes, possible renal dysfunction, since the patient, as we have mentioned a while ago, it could have already metastasized to other organs. So we should also ask for other symptoms such as oliguria, hematuria for possible renal dysfunction, headache, decrease in mental status, and decrease in sensory function and lethargy for a neurological defect, and severe hemorrhage as well in the lungs, in the brain, and in the GI tract. As for the physical exam, with the sign that we have seen from the patient, which is the obvious bleeding from the IV side, from gums, and from the mouth, aside from that, we could also look for other skin lesions such as ecchymosis, hematoma, a possible necrosis, and gangrene, as this may also arise in a severe or a chronic DIC. A patient in DIC may also experience acute respiratory failure and neurologic deficits. So we should also have a thorough and in-depth neurological exam for our patient. And then signs of splenomegaly and the liver should also be noted of. So going back to the lab results of our patient, um, he presented with low hemoglobin and hematocrit, um, presenting as anemia with neutrophilia, lymphopenia, a very low platelet count with a severe thrombocytopenia, and prolonged PT, INR, and APTT. So, using the information that we have gathered from the clinical history, the manifestation of our patient, and the glaring low platelet count, we can use thrombocytopenia as um, a possible explanation or a cause of the severe bleeding that we are seeing from our patient. So for possible causes of thrombocytopenia, we have differential diagnosis of DIC, TTP, ITP, and hemolytic uremic syndrome. So as I have mentioned, yun nga, we have thrombocytopenia across all these diseases. However, for um for TTP, the patient must have the five clinical signs of thrombocytopenia, fever, renal failure, microangiopathic hemolytic anemia, and neurological findings for us to diagnose the person as TTP. However, since it is not present to our patient, we can rule this out. Next would be the immune thrombocytopenic purpura. It also presents with thrombocytopenia and a manifestation of mucocutaneous bleeding seen in the patient, manifested by the gingival bleeding. However, for ITP, it does not involve coagulation activation and microangiopathic hemolytic anemia. So the other lab results would be considered normal. For the hemolytic uremic syndrome, the patient uh, manifested with thrombocytopenia. However, um, he did not manifest any bloody diarrhea, and his PT and APTT scores are increased. So um, we could rule this out based on this information. As for hemolytic uremic syndrome, this is usually caused by an E. coli infection, which would manifest into renal dysfunction and increased creatinine. However, in our patient, this is not. This leads us to our clinical diagnosis of disseminated intravascular coagulation, which is commonly presented as severe bleeding or blood loss from IV lines and catheter, and with a very glaring decreased level of platelet count, which would lead to bleeding, and also with a prolonged PT, APTT, and increased INR. These informations further supports the patient to be experiencing DIC.
Hello? Go ahead. Go ahead. Yeah, go ahead. So our primary clinical impression is disseminated intravascular coagulation. So what is DIC? DIC is a clinicopathologic syndrome characterized by widespread intravascular fibrin formation in response to, hello, bakit may ganun? In response excessive blood clotting activity that overcomes the body's natural anticoagulant mechanisms. In short, it is an homeostatic imbalance between coagulation and bleeding. So what is the incidence of DIC? The risk of DIC is particularly high in patients with sepsis. It is around 30 to 50% of septic patients, whereas the frequency of DIC is approximately 10% in patients with solid tumors, the brain, and obstetric calamities. Moreover, DIC is diagnosed in almost half of pregnant women with abruptio placenta or with amniotic fluid embolism. The overall prevalence of DIC in hospitalized patients is unknown because the established clinical scoring system for DIC are not systematically employed in clinical practice. Furthermore, the prevalence of DIC depends on the context of hospitalization, though it is higher in critically ill patients admitted in ICU. In this subset of patients, the prevalence of DIC ranged from 8.5% to 34%. So, as you can see here, table 112-2 summarize the common clinical causes of DIC. Though the most common causes are bacterial sepsis, malignant disorders such as solid tumors or acute promyelocytic leukemia. So what is the pathophysiology of DIC? The central mechanism of DIC is the uncontrolled generation of thrombin by exposure of the blood to pathologic levels of tissue factor. Simultaneous suppression of the body's normal anticoagulant mechanism and abnormal fibrinolysis further accelerate this, these processes. Together, these abnormalities contribute to systemic fibrin deposition in the small and mid-sized vessels. The duration and intensity of fibrin deposition can compromise the blood supply of many organs, especially the lung, kidney, liver, and brain, leading to organ failure. RBC is also damaged as they try to move past the thrombus inside the vessel. Hemolysis. The sustained widespread clot formation also results in consumption coagulation disorder. Coagulation leads to systemic bleeding. This is also further aggravated by secondary hyperfibrinolysis, which affects vessel patency and increase fibrin degradation product and D-dimers in the circulation.
The clinical manifestations of DIC are related to the magnitude of the imbalance of hemostasis to the underlying disease or to both. The most common findings are bleeding, ranging from oozing from venipuncture sites, petechiae, and ecchymosis to severe hemorrhage from the gastrointestinal tract, lungs, or into the CNS. Other clinical features of DIC is hypercoagulability. So the hypercoagulability of DIC manifests as the occlusion of vessels in the microcirculation and resulting organ failure. Thrombosis of large vessels and cerebral embolism can also occur. Hemodynamic complications and shock are common among patients with acute DIC. And in chronic DIC, the bleeding symptoms are discrete and restricted to the skin or to the mucosal surfaces. Extensive organ dysfunction may be induced by microvascular thrombi or venous and or arterial thromboembolism. Organ dysfunction may manifest as acute renal failure, hepatic dysfunction, and respiratory insufficiency due to acute respiratory distress syndrome. Coma, delirium, focal neurologic symptoms, and signs of meningeal irritation may occur because of thrombosis or hemorrhage in the cerebral vasculature. Limb ischemia leads to gangrene and loss of digits, and mortality rates ranges from 30 to 85%. The presence of DIC is a strong predictor for mortality in sepsis, trauma, and other underlying conditions. For the diagnostic test, the diagnosis of clinically significant DIC is based on the presence of clinical and/or laboratory abnormalities of coagulation or thrombocytopenia. The laboratory diagnosis of DIC should prompt a search for the underlying disease if it is not already apparent. There is no single test that establishes the diagnosis of DIC. The laboratory investigation should include coagulation tests such as APTT, PT, and thrombin time, and markers of fibrin degradation products, in addition to platelet and red cell count and analysis of the blood smear. These tests should be repeated over a period of 6 to 8 hours because an initially mild abnormality can change dramatically in patients with severe DIC. The most sensitive test for DIC is the FDP level. DIC is an unlikely diagnosis in the presence of normal levels of FDP. The D-dimer test is more specific for detection of fibrin degradation products and indicates that the cross-linked fibrin has been digested by plasmin. Common findings include the prolongation of PT and or APTT, platelet counts of 100,000 per microliter or a rapid decline in platelet number, the presence of schistocytes or your fragmented red cells in the blood smear, and elevated levels of TP. Because fibrinogen has prolonged half-life, plasma levels diminish acutely only in severe cases of DIC. In high-grade DIC, it is associated with levels of antithrombin 3 or plasminogen activity less than 60% of the normal. So for the DIC scoring system, a simple algorithm for the diagnosis of overt DIC utilizing platelet count, prothrombin time, D-dimers, and fibrinogen level has been proposed by the International Society on Thrombosis and Hemostasis. So here, you can see that if there is presence of an underlying disorder known to be associated with DIC, we give a score of 2. If the platelet count is less than 100, we give a score of 1, and if it is less than 50, a score of 2. If the level of fibrin markers is moderately increased, the score is 2, and if it is strongly increased, the score is 3. But a value above the upper limit of normal was considered moderately elevated, whereas a value above 5 times the upper limit of normal was considered as a strong increase. If the prolonged prothrombin time is greater than 3 seconds but less than 6 seconds, it is scored 1, and if it is greater than 6 seconds, it is scored as 2. And if the fibrinogen level is less than 1, the score given is also 1. So a total score of 5 or higher indicates overt DIC, whereas a score of less than 5 does not rule out DIC but may indicate DIC that is not overt. Prospective validation studies show that this scoring system is highly accurate for the diagnosis of DIC. The sensitivity of the DIC score for the diagnosis of DIC is 91 to 93%, and the specificity is 97 to 98%.
According to Harris, the morbidity and mortality associated with DIC are primarily related to the underlying disease rather than to the complications of DIC. Therefore, the primary goal of treatment would be the control or elimination of the underlying cause. Next, patients with severe DIC require control of hemodynamic parameters. So, if indicated, the next steps in the management would be to manage the hemorrhagic symptoms or the replacement of coagulation or fibrinolysis inhibitors. So for the first goal, which is the control or elimination of the underlying cause, we learned that infection and malignancy are possible triggers of DIC. And in our patient, we can relate it to him having an ongoing pneumonia and also the presence of stage 4 squamous cell carcinoma at the tongue. Therefore, we recommend to continue the antibiotic treatment for pneumonia. And since there was no prior data regarding if treatment was started for the stage 4 cancer, we recommend to start anti-cancer treatment. Next, for the management of the hemorrhagic symptoms, fresh frozen plasma or platelet concentrates can be given to a patient who is actively bleeding or has a high risk of bleeding. High risk of bleeding are patients preparing for invasive procedures or who have or are those after who have received chemotherapy. Another indication could be a low platelet count of less than 10,000 to 20,000 per microliter, given that the patient has marrow failure and is not clinically bleeding. Relating this to our patient has active bleeding profusely at the mouth area, therefore platelet concentrates are indicated and the dose would be 1 to 2 units per 10 kilogram body weight. And as we have learned from the lecture, they said the usual dose would be 1 unit to 10 kilograms body weight, but for special cases like DIC infections, fever, and splenomegaly, the dose may be increased to 1.5 to 2 bags per 10 kilogram body weight. Next, cryoprecipitate can be given to patients who have low levels of fibrinogen, less than 100 milligrams per deciliter, and who exhibit brisk hyperfibrinolysis. The dosage would be 10 units for every 2 to 3 units of FFP to correct the hemostasis. However, for our patient, there was no data acquired yet regarding his fibrinogen levels, therefore, and FDP, therefore, we can't say if he is currently in this hyperfibrinolysis. Next, the replacement of coagulation or fibrinolysis inhibitors. Heparin can be given to patients who have overt thromboembolism or when thrombosis is likely to cause irreversible tissue damage. It was proven to have an effect for low-grade DIC associated with solid tumors, acute promyelocytic leukemia, or in settings with recognized thrombosis. It is also indicated for purpura fulminans, surgical resection of giant hemangiomas, and or the removal of dead fetus, with a dose of 5 to 10 units per kilogram per hour, or according to Williams, 500 to 750 units per hour. However, in cases of acute DIC, heparin aggravates the bleeding. Therefore, it is not recommended. And this is the case of our patient, so heparin is not recommended for him. Next, antifibrinolytic drugs prevent fibrin degradation by plasmine, and it reduces the episodes in patients with DIC and confirmed hyperfibrinolysis. Those who may benefit from this are patients who have acute myelocytic leukemia or those with chronic DIC associated with giant hemangiomas. However, even though our patient is presenting with bleeding, I had mentioned earlier, we don't have any laboratory data yet regarding his FDP levels. Therefore, we cannot say if he is currently in primary fibrinolysis. And protein C concentrates can be given for those with purpura fulminans associated with acquired protein C deficiency or meningococcus, but this is not seen in our patient. So the prognosis of DIC, the mortality would range from 30 to more than 80% depending on the underlying disease, the severity of the DIC, and the age of the patient. So to end, here are the key points of our discussion. We learned that DIC is a clinical pathologic syndrome characterized by widespread intravascular fibrin formation. The most common causes would be bacterial sepsis, malignant disorders, and obstetric causes. The sustained activation of coagulation results in consumption of clotting factors in platelets, which leads to systemic bleeding, and this is what we observed in our patient. Bleeding is further aggravated by secondary hyperfibrinolysis, and no single test establishes the diagnosis of DIC, but relies on the presence of several clinical or laboratory abnormalities of coagulation or thrombocytopenia. And the treatment should foremost be geared towards the control or elimination of the underlying cause and management of hemorrhagic symptoms and replacement of coagulation or fibrinolysis inhibitors can be done if indicated. Thank you.
Hello, you have any questions, clarifications? We're about to finish the shift. Julie, your question. I have something to announce ba?
Wala naman, Doktora. So, for our next meeting will be on Monday. Again, you will have a lecture on biologics, cancer biologics, and then BGD, oncology, BGD. Okay, we'll see you on Monday.
See you. Take care, everyone.